and welcome back to Sepsis Voices with Dr. Ron. That's me, Dr. Ron Daniels. I'm the UK Sepsis Trust's founder and chief medical officer, and we're recording this during International Infection Prevention Week, a global initiative dedicated to raising awareness about the critical importance of infection prevention. And if we prevent infections, we'll reduce the number of cases of sepsis, of course. That feels particularly fitting as today we're going to talk about surgical mesh. Joining me for this episode is Kath Sansom from Sling The Mesh, which she launched in 2015 following her own experience with a TVT procedure. Now, this is a procedure to help reduce bladder leaks, particularly after childbirth. It's a very common procedure. Sling The Mesh provides support and advice for those who've been left in pain after being fitted with surgical mesh implants used to treat things like prolapse and incontinence, hernia repairs, and in some cases for cosmetic reconstructive surgery, for example, following mastectomy. So welcome, Kath, and thanks for being here.
Thank you for having me on.
So just to start with a bit of background for our listeners who might not be aware of what surgical mesh is. Surgical mesh is a usually permanent polypropylene plastic implant. They're used in procedures, as I've said, like hernia repair, like pelvic floor surgery, but for some people, complications can have life-changing consequences. Like with any surgery, there's a risk of an infection developing that can sometimes lead to sepsis, a life-threatening condition that claims 48,000 lives in the UK each year. Now, here at UKST, we're all about raising awareness of sepsis and encouraging people to learn the signs so that if they or someone they love has an infection, then they know what course of action they should take if things start to seem to be getting worse rather than better. And ultimately, higher awareness levels are going to save lives. So, Kath, that's our charity's purpose, and we'll come on to your campaign's aims in a second. But could you start perhaps by giving us an overview of your own personal story? Well, in whatever level of detail you feel comfortable sharing.
I always describe myself as an accidental advocate. I never intended to set out to campaign at all. I was just a mum of two living in Cambridgeshire. I was working as a journalist at the local regional newspaper at the time. I also ran my own photography business. And I found as my girls were entering their teens and I had more free time, I was doing more exercise, but also I went into perimenopause. And like a lot of women, we find that you after childbirth, you might experience some minor leaks, but as you go into menopause, you may notice it a little bit more. So I went to my doctor who referred me to the local hospital, and I was told I was very lucky because I was the exactly right candidate for this particular procedure. And that there was I wasn't explained any risk at all, other than the standard. There might be a little bit of bleeding afterwards, but it was a really low risk surgery. I had no idea it was a permanent device. I assumed it was a bit like a contraceptive coil, so if I didn't get on with it, it could be removed. So I went along for that surgery, and I came out in enormous pain. And again, I didn't think too much of it, but as the days went on, it got worse. Pain in my legs, pain around my groin, my hips, and I went online and Googled this operation that I'd had. And some people have said to me, why didn't you Google it beforehand? Well, I trusted my doctor and I trusted I was given the correct information. Anyway, I went online and I found that the surgery I had actually been suspended in Scotland the year before. And I found pockets of women trying to raise awareness, but their voices weren't really being taken seriously. So as a journalist, I knew I had, say, the writing and comm skills to set up a campaign group. So I set up in 2015 with 20 members, and it's now got more than 12,000 from around the world.
Goodness gracious. And as a health professional, it sounds to me as if you weren't adequately counselled for your procedure.
No.
It sounds to me as if your consent was inadequate because, we should always inform people, and the rule of thumb for health professionals is that we should inform people of every complication that affects more than 1% of people, but also every life-changing and catastrophic complication if it affects more than 1 in 1,000 people. So, you should have been told about these things. I think, unless you disagree, we should reinforce at this point that TVT procedures have helped many thousands of women around the world, but you're absolutely right that complications can occur and people need to be counselled.
Yeah, and I need to let you know at this point that this particular operation was suspended in 2018 by Baroness Cumbledge in her first Dunahan report because she found that the level of complications and the lack of informed consent was wholly unacceptable. So it has actually remained on suspension for the last 7 years.
Goodness, no, I wasn't aware of that. I used to be an anaesthetist and would occasionally anesthetize for urogynecological procedures, but I haven't been an anaesthetist since about that time. So I wouldn't
Okay.
know that it had
Yeah.
since been banned. I mean, there is a need for women who do suffer bladder leaks for something to be done. So what are the alternatives now?
Well, the alternatives is something called a cold post suspension, which is a little bit like a hitch and stitch is probably the best way I can describe it, where everything's like stitched up. So it's almost like it's just stitching. And there's also something called an autologous sling, which where you use the patient's own muscle to create a sling to support the urethra. And of course, good quality pelvic floor physiotherapy can fix or ease things for 80% of women. So what we found was happening was this operation was being over promoted, where the benefits were overstated and risks were downplayed. And the shame about that was the traditional and trusted old school methods were being pushed to one side in favour of this particular mesh surgery, which is a great shame. Mm.
Yeah, because cold plate suspension is a much older procedure and one that
Yeah.
was commonly used before TBT became, I suppose, fashionable. And
Yes.
we should explain TBT stands for tensionless vaginal tape, or stood for, I should say now.
Yeah.
So obviously this inspired you to start Sling the Mesh, and as someone who has founded and started a charity, it can be very hard work, can't it? What was your experience in starting your organization?
Um, well, I've never set up as a charity actually. I was always very adamant that I wanted to remain a grassroots advocate, and I've been doing that for a decade. But I have reached a point where juggling this and full-time work is really difficult. So I am going to be setting up a charity soon to try and pull back some hours to do the work I do. Um, in all honesty, the fact I was a journalist at the time probably made it a little bit easier because I had the power to be able to tell stories. So I could write the stories of women who were suffering and tell their experiences. I started realizing there was quite a lot of flaws in the scientific literature where the data wasn't being captured on complications. So I could start to write stories about that. It gave me power through my pen, if you like, proverbial pen, to gather political momentum and get my campaign into Parliament. So within 3 years of starting the campaign, Jeremy Hunt announced an independent review into mesh procedures. And I do think being a journalist helped me. That aside, you'll know it's such hard work and it's my passion project, and I don't stop. It consumes my days, my nights. I'll be on holiday round the pools, emailing, politicians, other women, anyone supporting posting to social media. The work never stops behind the scenes. It's really busy, but I'm so adamant to do the right thing and support other people and raise awareness that here we are.
Yeah, no, you raise a really good point that, this is people look at someone like you, look at someone like me and think
Mm,
this is a bit of a hobby, a bit of
yeah.
a bit of a soapbox, and we do a normal job and then spend an hour or two a week
Yes,
doing this stuff. It is all consuming. It
it is.
genuinely is. And like you, I gave up many, many hundreds of hours of my life over many years
Mm,
voluntarily, but eventually something has to give. And I
yeah.
don't think, I'm not ashamed that, I'm now employed by the UK Sepsis Trust and I'm
Yeah.
contracted to many hours a week. And yeah, I don't think any of us should be ashamed that actually to do
Yes.
this properly, shock horror, person gets paid for the work they're doing, that we
Yes.
should actually, uh, you know, not benefit, but actually ensure that we can continue to live our lives and provide for our
Yeah.
dependents while doing what we believe in.
And looking after our well-being. I think that what really made me realize I need to set up as a charity is last year I was super lucky. I won something called the Tenacious Campaigner Awards. I was one of 10 winners and I was given some funding. So for the first time in a decade, I had some proper funding. And I'm like, oh my God, this isn't, it literally has come from my back pocket. The website, the train fares, the advocate, all of it, having posters and banners printed, everything is from my bank account. And you reach a point where there's saturation and you can't grow anymore. And I think that's what I found frustrating. I need to do more, grow more, but I can't do that within the constraints of running a full-time job as a single parent. It's tough, and I do look after my well-being. I go boxing, which is amazing. For my overseeing a page of deeply harmed people, I feel this sense of anger and wanting to fight for justice, and boxing really helps me. I also go to quite a lot of gigs and concerts and walking my dog. And that's great. But there comes a point where I'm just time poor. And there comes a point where you need to address that for
Yeah,
sure.
no, I honestly feel your
Mhm.
pain, and I think, as I said, people sometimes don't realize quite how
No.
all-consuming this sort of work is. So, um, just coming back to mesh for a moment. So, from your perspective, uh, obviously you've looked at all sides of this. Obviously, you're approaching this as a campaigner, but not a an entirely bitter campaigner, and you will have looked at this in a balanced way. So, what are the intended benefits of mesh, and why do you think mesh of various types was introduced so widely into surgical practice?
So the intended benefits are that it's to strengthen weakened tissues. Um, Another benefit is that it probably doesn't require so much a surgeon's skill as the old school repairs in any hernia, incontinence or prolapse surgeries. I almost liken it in my talks to Wonder Web. So if you want to take up a pair of trousers and you want it done really, really well, you give it to like someone's mum or like the seamstress in town and she'll do a really super job. But if you kind of want a quicker job, you're like, oh, well, I'll get some Wonder Web and there we go. That's the best way I can describe it in layman's terms, and that people are probably sitting listening, feeling horrified. But it's that quick fix. It's easier, it's quicker, it's cheaper. The accountants like it. It's less time in surgery, less time maybe in recovery. And on paper, it looks amazing. But the key problems I think is that yes, it probably does fix, but it might only be a short-term fix. But what's happening is there's no long-term follow-up and data collection of patients. So for example, for me, I was only followed up 6 weeks after my surgery, and that was it. So on paper, I look like this huge success, as do thousands of others within my group with whatever mesh they have. And mesh has this almost ticking time bomb quality to it, whereby over weeks, months, years, it can shrink, it can twist, it can degrade, the edges can harden almost like an internal knife, so it can start cutting into tissues and nerves. We have members in the group who have had their mesh sliced into organs. They've had to have bladders and bowels removed. We have men who've had hernia mesh and that's sliced into their spermatic cords. I mean, these aren't little injuries, these are life-changing and oftentimes devastating complications. For women, it sliced through vaginal walls and cut their partners. And I apologize if these are terrible graphic details, but uh, this is the reality of mesh, but also it's not instant. So, of course, if you're only followed up at 6 weeks, the data's not capturing you at a year, 5, 10, 15, and even 20 years. And in fact, one of the members of a group, her mesh didn't start slicing literally her urethra until 16 years later. So I think this is a problem in the way that our patients are followed up. Um, there's not that long-term capture to prove there's a problem.
Yeah, that's interesting, and I find that surprising. Again, as a no longer anaesthetist, so I'm unaware of these things. But I know that, for example, if a woman has a breast implant or a man has a
Mm,
breast, anyone has a breast implant,
yeah.
whether it's for purely cosmetic reasons or for reconstruction after mastectomy, that there is a national register, isn't there? So you've
Yes.
got a prosthetic device being put into a patient, the serial number's recorded, the patient's details are recorded, and if
Yes.
there's any complications in the future, they can be followed up. So you're telling us that that does not exist for mesh.
Well, no, it doesn't. So I'm glad you've moved on to this actually, because one of my campaign aims, so I've obviously knew about the PIP breast implant scandal and the joint hip joint scandal and the so there's a joint registry and there's a breast implant registry. So I knew about that and was horrified that there was nothing like that for mesh or indeed any other high risk implantable devices. So one of my key campaign asks was for a registry for all medical devices. So that the work on that started a couple of years ago, and that is being rolled out as we speak. It should be completely finished by April 2026. So yes, indeed, it's called the Medical Devices Outcomes Registry. Mesh will be logged going forward, as will many other high-risk devices. But a nuance I found out last week, which blew my mind, was the contraceptive copper coil will be logged on that registry, but the contraceptive coil Mirena won't be, because that's considered a medicine because it has the additional layer of hormones within the Mirena coil. So we're still in a situation where there's like black holes of data to kind of to be able to pause and stop treatments if they're causing harm. We need to be able to have early warning signs, and the data and the regulation and the oversight just isn't there. And that's not just for the UK, that's globally actually. It's been quite a wake-up call and a shock to me to realise how it's not as robust as it should be for patient safety.
Yeah, absolutely. And you've just put me in mind of someone I've been speaking to in North America who's, they claim, and there seem to be some substantive claim there, that they've been harmed by a device that releases a drug slowly. And similarly, there seems to be
Mm,
no accountability and no
no.
follow-up for these. So, I find that surprising and unacceptable as a health professional. And
Yeah.
I'm sure most responsible members of the health profession will welcome such a registry because,
Yes.
we have it for drugs, don't we, with the yellow card system and so forth. So, why shouldn't there be some way of identifying a problem or a risk that we were previously unaware of?
Absolutely. And there's two things to mention there. Nobody sets out to harm a patient. They don't. They really don't. This is unintentional in many ways, and sometimes avoidable harm. And the second thing, we do have the MHRA yellow card. When I first started campaigning, I didn't know about it. And when I was told about it, I'm like, well, isn't that a football reference? What's a yellow card? I had no idea what it was. And then I had no idea it's not mandatory. So by law, doctors don't have to log. So I'm not saying it's voluntary, but doctors are busy people. So of course, and that's another. If I give you an example, in 2012 there were 1,000 women harmed by mesh, and that the hospital HES data showed that. But the yellow card reports had only had four. So out of 1,000 like women suffering, only four had been logged to the yellow card. So these systems are set up, but they're kind of failing. And again, it's not intentional, but it does take people like me, and there are other obviously patient safety campaigners out there just trying to raise that awareness, and you can self-report, so there is a bit more awareness out there about the yellow card to self-report, but there's things that are set up with the best of intentions and they don't quite capture what they're
Yeah,
supposed to be.
yeah. No, absolutely. You've talked, in not horrific detail, but with some degree of graphicness, if that is a
Yes,
word, about the physical, the sort of anatomical
yes,
complications of mesh, which sound that they can be completely life-changing.
yeah.
Um, do you have any data on how many people suffer infection as a consequence of mesh insertion?
Well, for women's mesh, yes. So we run regular surveys on the group, and we found that around about 50% have constant urinary tract infections, and of those, around about 10% are finding that they're becoming resistant to antibiotics. So they're not resistant yet, but they're finding that these antibiotics aren't working. They're needing to keep trying different ones, or they're ending up in A&E, either with sepsis or with suspected sepsis. Um, Now, it's difficult to get across how this is not often recognised or even understood by healthcare professionals. When a woman presents in A&E, for example, saying, I think I've got sepsis from my mesh," and they'll be like, "Well, what is mesh?" And you can't expect every doctor to know about everything. It's impossible. But there certainly needs to be more awareness around what that means if a woman said she's had mesh, because our understanding is that when you're inserting a piece of polypropylene plastic through the vaginal wall, you're going through a clean contaminated field of bacteria, if you like. So for some women, it's almost like it creates microfilm around that plastic, which is like a host to bacteria, and they just keep getting repeated infections. Some don't, but some do, and they're back and forth, and not only are these infections not quite going away properly, but the women start to feel like they're being a nuisance at their local GP surgeries. They're not really quite understood, and it's really difficult for them because these infections can be so uncomfortable
Mm.
for them to live with.
Absolutely. And obviously you mentioned earlier being perimenopausal, but infection as a consequence of hormone changes and vaginal
Yes,
dryness becomes more common,
yes,
doesn't it, as well? So
yeah,
it's almost like a double whammy,
it
making
is.
people's lives miserable. And we've worked over the years with many, particularly women, particularly perimenopausal women who've suffered chronic infection. They've almost
Mm,
needed ongoing courses of antibiotics for months and
yeah.
months and months to deal with their problem. And these are really important issues. Are you aware of any people on your radar who have progressed with an infection to develop sepsis?
Yeah, many, to be fair.
Mm.
That there are many who then they sort of appear at it's quite common to appear in A&E at like 3 in the morning, especially at weekends. I don't know what it is about weekends and it's like I've got a UTI, it won't go away, I'm really ill, and then suddenly it's realized, oh, actually this is serious. We need to get intravenous antibiotics into them. So there have been many, it's not a small number of isolated incidents. It's not that uncommon. There was one particular woman. I mean, I know this is in Canada, but she actually just lived on that line with a like a little mobile bag because nothing in the end would get rid of the infection from her bladder mesh sling. And I'm so sorry to say it, but she actually died from sepsis. She had little boys. That was a few years ago. There's been a couple of other deaths on the group where we're we're sure it's because of sepsis. Sure, it's related to the mesh, but it's never written on the coroner's notes or on inquest notes or anything. So it's not something we can prove. It's very difficult for us, but we know the woman's history from seeing a post on the page. I've got no infection. Oh no, I'm in hospital again, and yeah,
Yeah.
it's upsetting. It's really
Yeah.
difficult.
Yeah, obviously more than upsetting. And, we talk a lot about sepsis and the importance of early recognition. And I think, we take some credit for the fact that most health professionals are now aware, as well as the public,
Yeah,
that it's a medical emergency and we've got to get antibiotics in quickly. But, another part of that message that we deliver to health professionals is if there's a source of infection amenable to removal, and we commonly talk about an indwelling catheter or a deep-seated abscess, no amount of antibiotics are going to fix the problem. You've got to get
yeah,
rid of the source, and that would include in this situation or in these
yes,
situations removing the mesh. But of course, although mesh going in is like Wonder Web, removing mesh is surgically very technically challenging and,
it
and,
is.
and a major surgery, isn't it? So
It is.
you've got this sort of conflict between something that you know is causing these ongoing infections and causing these
Yes.
episodes of sepsis and the huge complexity and risk of removing that source. It's not as simple as taking a catheter
No.
out.
No, it absolutely isn't. And you've really hit, I'm really glad you've raised this point, actually. I feel super lucky. I had my mesh removed 7 months after it was inserted, and I had it all taken out in one go. It hadn't been in as long as some people's, and I live a pretty good new normal. I had a really good recovery. But of course, some women, their mesh has been in 5, 10, 15, some even 20 years, and it's embedded really quite deeply for a start. It is risky, difficult surgery. Surgeons can't always find it to be able to get all of it out. So some think they're getting a full removal or told they're getting a full removal, and that hasn't happened. So there's still elements left in. Part of my campaigning led to the NHS setting up 9 specialist mesh removal centres, but it's still almost an early specialism, if you like. So there's not joined up. I said not joined up pathways of care. Depending which centre you're at, you get different. I call it a postcode lottery. There needs to be a lot more training. But it's difficult. It's a really complex area of surgery. This stuff wasn't designed to come out. It knits into tissue. And some people have described it as trying to get chewing gum out of matted hair or trying to dig something out of hardened concrete. It's difficult. But you're right. If that's the thing that's causing the infection, it's just going to keep causing problems. And then, of course, we come to the women who feel almost a sense of guilt that they're being annoying, that here they are again back at my doctor's with another infection, and or here I am at A&E, and they feel this sense of deep burden and guilt that they're needing to be fixed again.
I want to talk about something that I saw on your website, which shocked me about an Oxford University professor
Oh
who
yeah.
it appears was on the brink of getting the
Mm.
sort of the netting that we, buy our oranges or our satsumas from in
Yeah.
the supermarket approved as a vaginal mesh, really just to prove a point about how bad the medical device approval system, so equivalents in Europe, the 510(k) system in the US,
Yes.
how bad these systems are. So,
Yeah.
can you tell us a bit about the scientific evidence base for surgical mesh and what you want to
Yeah.
see changed in terms of the regulation and rollout of new products?
Yeah. So and Professor Carl Hennigan, he's been super supportive to my campaign, and I've done various talks alongside him where he talks about what he did. He literally was on the brink of getting orange netting approved as a medical device. My talks often say, you know, a kitchen toaster probably gets more safety checks than a medical device. That's how weak the systems are globally. So what happened in terms of mesh is hernia mesh was being used. Probably from the 80s, and deemed to be successful at that point. And in the 90s, they realized that, well, actually, if it's being successful to strengthen weak tissue for hernias, maybe it can shore up urethras to stop bladder leaks. So they developed the bladder mesh sling. And all they needed to do to get approval was to say, well, this women's vaginal mesh is equivalent to a hernia mesh. It's almost the same. And then they got approval. So it was like rubber stamped through. That's how easy it is. It's insane, isn't it? And then
Yeah.
that particular mesh did women's mesh started causing quite a lot of problems. So that was quietly sort of removed from the market, not and no one ever heard about it anymore. But by then, of course, other companies have stepped in and had got their device approved on the back of that first women's mesh, which is on the back of hernia mesh. Like it's called grandfather approval. So these meshes just kept getting approved and approved and approved on the basis of no clinical evidence, no long-term data follow-up, no post-market surveillance, no data capture, and yeah, it blows my mind that that's still the situation. Unless you can get in the UK, I've had mesh raised to high risks, which is a classification 3, which means it needs a little bit more post-market surveillance. But we're still in this situation where most medical devices are approved on equivalence. Mm.
Wow. Yeah, I mean, it's pretty shocking, and obviously Carl Hennigan's got a really good name for himself as a sort
Yes.
of a disruptive
Yes.
professor, and
Yes.
he's done some great work, and but I think it's still shocking.
Yes.
So I think as a health professional, I really should emphasize, and I know you haven't said this, that all mesh is not inherently bad, but particularly when there's high degrees of tissue loss and there is simply very few or no other options, and particularly where every other surgical option has been explored and failed, or every other non-surgical, then sometimes this can be appropriate if used appropriately. When there's been huge loss of abdominal wall muscle
Yeah.
and people have, essentially their bowel is just underneath their skin, which is extremely
Yeah.
risky, and it simply can't be reconstructed any
Yeah.
other way. So these are rare cases. Would you agree with that, or would you disagree with that?
It's a really tricky question to answer because obviously I'm at the coalface of seeing the harm and people's lives absolutely devastated. You know, they've lost marriages, houses because they can't work anymore, they've lost jobs, pensions, their sense of self, their well-being. There's a high level of anxiety, depression, PTSD on the group. So it's a difficult question for me to answer, first of all. But I do see there are cases whereby, if there's a hernia that's large, and native tissue overstitching is not going to fix it. My opinion, and I'm not all mesh campaigners would agree with me, is that instead of using polypropylene mesh, then why don't we start more widely using biological mesh, which is made from it's usually bovine or porcine mesh, so it's not the polypropylene plastic. There still are people on my group that have had biomesh that have suffered harm, but nowhere near. It's tiny, tiny amounts. That almost feels like that's a little bit of a safety net, maybe, because I do recognise that in some cases it is needed. But I think that the key thing underlining all of it is what we must be so mindful of is fully informed consent, because at least then the patient can weigh up the benefits versus the risks. So, for example, I would say 95% of the group that had my type of surgery, we weren't warned of any risks at all. Now, if it was a life or death surgery, yes, I'd have taken the hit. I'd have taken the risk, but it wasn't life or death surgery for a lot of us. It was quality of life surgery, and actually knowing that pelvic floor physiotherapy could have fixed 80% of us, to be fair. So there's a lot of women who've had a life-changing surgery that they perhaps didn't even need. That's like a punch to the gut. So I think to try and answer your question, let's switch from polypropylene mesh to biomesh, and let's have properly informed consent, fully informing of the risks of surgical mesh, because patients just aren't being warned.
Okay, no, I think that's a very fair and balanced answer, and it highlights that, um, people like me who are experienced clinicians don't know everything that's going on in this field, and so it's important that we have, advocates like you pushing for change. So obviously, it's still happening today. So if you hear of someone who's had a mesh procedure and perhaps they're recovering from it, or particularly that they feel something isn't right, they feel that they're not recovering as they should, what would your advice be?
I suppose in the first instance would be to join the group, join the Facebook support group. It's a closed support network of men and women, and also family members who are supporting the mesh injured community. So it's for such a big group, it's surprisingly welcoming and positive and supportive. So join that. If you don't feel quite comfortable doing that, then there is the website with lots of resources and information on there. There is a letter. It's predominantly aimed for women to take to their doctors that lists mesh complications, and that has been approved and signed by our Patient Safety Commissioner, Henrietta Hughes. So that's there on the resources section. They're probably the first two things you can do, because it can feel very overwhelming. But connecting with other people who understand you, I think, is really powerful.
Okay, yeah, thank you. Now, obviously we've talked a lot about mesh. We've talked about the need to prevent avoidable infection, as well as all of the, as I've described, anatomical and physical harm. And you've mentioned the psychological harm, which of course we see after sepsis as well. And, I think all of this really, to my mind, comes down to proper informed consent,
Yes.
perhaps using biomesh instead of synthetic mesh, um, considering any implant as a last resort,
Yeah.
surgically, having explored all other options, and following up with a clear, accurate registry, so that if unforeseen problems do exist, then we begin to learn about them and we can take action. So, it'd be remiss of me not to ask you as a journalist this question. Is there anything sort of that we haven't spoken about today, or anything in that sort of micro summary that you'd like to add?
There is. There's part of our campaign is pushing for compensation for women. It feels deeply unfair that they've been avoidably harmed from something they trusted was safe. And I know that's a really difficult topic of conversation. And something else that we're pushing for in the campaign is sunshine legislation. They have it in America, and that would mean industry is mandated to disclose all of the money it gives to the health sector. Because what we found in the mesh scandal, and I sometimes I use the word scandal hesitantly, but where there's been other healthcare treatments that have caused harm, conflicts of interest have played a part, knowingly or unwittingly. If you've received money from industry, it can bias prescribing options. It can affect research integrity, and that was certainly something that happened in this mesh scandal, where perhaps in trials benefits were overstated and risks were downplayed. And I think for campaigners to be able to have a look at those conflicts and to be able to assess them and assess the scientific literature in a more neutral way would be really helpful for advocates going forward.
Obviously, very best of luck with that, as well as
Thank you.
all that you're doing. And I'm sure many people listening will want to join me in thanking you for everything you're doing to make sure not only that patient voices are heard, but also that proper and precise actions are being taken to reduce harms to, you've said primarily women, but of course it's not exclusively women, as we enter the next decade. Now, we're going to be collaborating with your organisation to produce a Sepsis Voices case study that highlights the risk of sepsis among patients who've received surgical mesh implants. So thanks again for working with us to coordinate that. Now, if you'd like to find more about Sling the Mesh, visit the website, which is slingthemesh.co.uk. And remember, if you or a loved one are recovering from any medical procedure and feel unwell, or if you're not recovering as you might expect, trust your instincts. And if you think there's an infection there, just ask, could it be sepsis? Now you can even use our free sepsis assessment tool via our website. It's a Class 1 medical device, and it will help you to decide if and when to escalate the situation. It might even tell you to go straight to A&E. Just head to sepsistrust.org to learn more. As ever, thank you for listening, and we'll see you next time.